all disease begins in the gut. Now we know, paper after paper after paper after paper, really validating everywhere is influenced by the microbiome.
The father of medicine, Hippocrates, would marvel at GI360 and the technology that we really do have at our fingertips. Sometimes individuals are trying to self-treat their IBS or their IBD with the carnivore diet because it's that ultimate elimination diet, but they're actually making their situation worse. Stress itself can induce intestinal permeability. Individuals are stressed due to our everyday considerations. It actually takes 2 weeks for the environment and the microbiome to remediate itself.
Hi, listeners. It's hard to believe, but New Frontiers in Functional Medicine has been going strong since 2015. With over 200 episodes and over 2 million listens, we are growing every year. My goal is to continue to bring you the best minds in functional medicine, epigenetics, and longevity. I want the content to be actionable for the functional medicine clinician and interesting for the rest of us. Thank you for supporting this podcast with your likes, with your honest reviews, with sharing the episodes with your friends and family. And if you haven't done so, please consider leaving a like or leaving us an honest review wherever you've accessed this podcast. Thank you, thank you, thank you to our sponsors. Because of our sponsors, these are companies that I trust, that we vet carefully, that we use in clinical practice, that I use personally. Because of them, everything associated with this podcast is free. If you haven't done so, I suggest you head over to DrKF to the podcast page where you can access the full transcript for every single one of these 200 episodes. And along with that transcript, you'll get an episode summary. You can get the research citations and additional content that is pertinent to the episode. I myself return to the transcript page all the time to pull out a little snippet of information that I want to recall or access a citation. Or better yet, sign up for our newsletter, again, at drkf and every single podcast episode will drop in your email as soon as it's released. Thanks again.
Hi, everybody. Welcome to New Frontiers in Functional Medicine, where we are interviewing the best minds in functional medicine. And of course, today is no exception. We are going to be doing a deep dive into Doctor's Data GI360 report. In fact, hit pause, go to the show notes page and grab the sample report and have it in front so that you can move through that document with us. And then you're just going to really get to understand the juiciness of the utility of this particular lab. But let me introduce you to my expert. You can see her sitting next to me if you're on YouTube. This is Dr. Julia Malkowski. She is an ND-DC, and she's got her bachelor's in science. She began her career in functional medicine upon seeing excellent results in her infant son. And then she went on to complete her own bachelor's degree in biomedical science, her doctorate in chiropractic, and her doctorate in naturopathic medicine after, all while raising her healthy family. She remains committed to optimal health on a personal and professional level as a staff doctor of clinical education at Doctor's Data, and she maintains her own private functional medicine practice, Dietary Health, outside of Chicago. Julia, Dr. Malkowski, welcome to New Frontiers.
Thank you so much for having me here. It's an honor to be here, and I look forward to having this conversation today.
Yeah. So again, you guys hit pause, go grab the sample report because we're going to dive in from the top, looking at the GI360. So there's a saying, actually, many moons ago, all disease begins in the gut. And now we know, paper after paper after paper after paper, really validating the gut systemic connection. Really everywhere is influenced by the microbiome. Talk to me about where we continue to learn in this arena, areas that you're interested in, and how the GI360 works to really help us perceive what's happening in the gut that may be influencing systemic health.
Yeah, absolutely. Great point. Certainly, the father of medicine, Hippocrates, would marvel at GI360 and the technology that we really do have at our fingertips to understand this connection and also as a tool for our patients to understand. So GI360 represents microbiome. It represents microbiome abundance, diversity, dysbiosis. It can give us clues about intestinal permeability. It can give us clues about the patient's diet. It can give us clues about compliance with our dietary recommendations. And really, it does provide a tool to understand this connection. We know the gut microbiome is linked to chronic metabolic diseases, of which chronic disease is spending 90% of healthcare expenditure right now. So this is a consideration that we can really help our patients. We also know that Westernized diets, specifically the standard American diets, are connected to chronic disease, and the gut microbiome is a link right there.
Awesome. All right. So let's talk about, you just made the point about we can see what our patients are eating. I mean, it's extraordinary. Many years ago, when I was in the lab, we used to see a lot more trans fats. So, on the fatty acid report, we would look at the omega-3s, the omega-6s, trans fats saturated, and there were a lot more trans fats than we're seeing today. I think actually, industry has gotten a little bit savvier about removing them. But I could see immediately into whether I thought my patient was eating well or not just by looking at those data. But now you guys have really kind of created this cool opportunity for us to see how food and other interventions, medications and so on and so forth, are influencing the gut microbiome. So speak to that. And again, you guys open your sample report now. Okay, I've got mine.
Yeah, absolutely. This is a great tool to understand what the research is telling us about the microbiome, about phyla, about specific keystone bacteria, about functional groups of bacteria. We call them functional guilds of bacteria. They work together. So you can understand exactly where your patient is on these matrices that we're hearing about in research. So the first thing we see on the profile, we see the 6 main phyla that are well researched, and you can actually tell your patient's level of these phyla. This is important because some phyla are more inflammatory. They correlate, and some phyla correlate with anti-inflammatory properties. So you want to see not only where your patient is with those phyla, but where your patient is with regards to the relationship between the phyla, and that's when we're talking about diversity, how these interact with each other and where they lay in regards to one another. So you don't want too heavy for the pro-inflammatory phyla, such as proteobacteria and maybe Bacteroides, and you want a abundance of those healthy anti-inflammatory phyla, such as actinobacteria, firmicutes, and then also that Verruca microbiota phyla.
So having the sample report open, there's a cool hexagon with these phyla represented. And at a glance, I can see this individual is biased towards a more pro-inflammatory, phyla distribution. And then we can look down, we can just look at the dysbiosis index below and see that, that this individual has some pretty serious dysbiosis. So talk to me about the nutrients influencing, I guess just at a glance, we can look and see this is biased towards pro-inflammatory. Like if this is all we had, what would we do? How would we change what they're eating to shift this diversity summary?
Yeah, exactly as you're mentioning, this is an at-a-glance information, and you can tell right away from that hexagon. And also, this is a great tool to show your patient your results. Yeah, it's this web.
So what are they eating? Tell me what, go ahead.
Yeah.
Sorry.
No, you're fine. So their web is that white reference, just so you so individuals understand, and it's superimposed on the green hexagon, which is the normal biotic reference range. So for this patient, they are lower in that top left corner, actinobacteria, because you can see how that point of the web is pulled in.
Very low, yeah.
And then same thing with the Verruca microbiota, that is the top right-hand corner, and that's pulled in as well. So we like to think about what these phyla enjoy eating. For the actinobacteria, that top left-hand corner, they like eating vegetables and also soluble fibers in that category as well, but really vegetable consumption, cruciferous vegetables. And then the top right corner, Verruca microbiota, they really enjoy polyphenols. And the polyphenols within there, we're thinking about Akkermansia eosinophila. We're also thinking about pomegranate and those types of things. So this individual is deficient in vegetables and polyphenols.
Interesting. So you could just at a glance tweak this. I want to, and I want to talk to you. I know we'll get to this, so maybe I'll put a pin in this right now and we'll kind of further analyze what's going on in this individual based on their lab data. But what other dietary patterns? So if you didn't know this, if you didn't have any data other than this, would you be assuming this person is eating a standard American diet, sort of higher in fat, maybe higher in processed, nutrient void carbs? Like what does this data tell you they're probably consuming?
Potentially. One of the key findings for the standard American diet, for that Western diet processed food, is that bottom right corner, proteobacteria, it will be pulled down and skewed toward that section there. So you will see that quite often in patients that are on standard American diet. So that was a real a red flag, if you will, for that. And conversely, you will also see those lower actinobacteria and Verruca microbiota as well. Yet you can see nuances in some individuals, even individuals that are vegan diets, right? We think of vegan as vegetarian diets. These are highly educated individuals. These are health conscious individuals. Sometimes you will see lower actinobacteria and Verruca microbiota because they are eating processed foods. They're not eating those whole foods. Yeah.
Wow, that's really interesting. So you could actually see higher proteobacteria or Firmicutes in that population as well. And then you would say, okay, we know you're a vegan, but you're not eating actually vegetables. Interesting. So they're eating like, I don't know, the lab burger and, and a bunch of pasta and
toast. Yeah.
That's so fascinating. What is it? We're jumping ahead to a question that I had for you later, but what's a carnivore look like?
Ooh, good question. So with the carnivore diets, so I tend to notice dysbiosis. So we'll talk in a minute about the dysbiosis index, but as you might consider, these individuals are not consuming produce and they're not consuming legumes. So they tend to be lower in that actinobacteria and the Verruca microbiota. They tend to be lower sometimes in the Bacteroides, Firmicutes, but that's a nuanced phyla because there's a lot of bacteria within there. And certainly skewed down to the proteobacteria, as we mentioned, very inflammatory profiles. Now so, and then we'll talk about other findings on the report, but I do, I do note that, and you've seen this in your practice as well, is that sometimes individuals are trying to self-treat their IBS or their IBD with the carnivore diet because it's that ultimate elimination diet, but they're actually making their situation worse, as you can see on the phyla there.
That's an incredible pearl. I mean, without question, I will use a very strict keto diet in certain, when I'm trying to, aggressively address certain conditions. Maybe, somebody who's on the diabetic continuum, we've used the Tom Seyfried caloric restricted ketogenic diet. We've used a similar dietary pattern when we're treating individuals with refractory epilepsy and so forth. And actually, there was some interesting research looking at using a keto in bipolar. So it seems to me that these dietary patterns have their place. But when you and I were talking offline, you talked about like pulsing it or paying attention to how the intervention is influencing the microbiome. And it makes sense that we would, when we do an extreme dietary pattern, obviously we have to pay attention to nutrient repletion systemically. And we really need to be paying attention to the gut microbiome as well. And if symptoms warrant, like i.e., if we can increase some veg into this individual and maybe lower the quantity of protein in this individual, that, we could switch this pattern and really make the prescription safer. What are your thoughts on that?
Exactly. I wholeheartedly agree with that. I certainly agree with the concept of cycling, and I certainly agree with addressing an individual's motivation for a specific diet. You're speaking to medically recommended diets. That makes sense. A lot of people are hearing anecdotal evidence about carnivore diet and ketogenic diet, and doing them without the guidance of a physician.
Yeah. And we could see, and you have seen this, I'm sure, but you could see some pretty horrific fallout when somebody's adopted this dietary pattern long term. We could have our whole conversation on it. So this is awesome what you guys have created in at Doctor's Data, this at a glance tool. I love it. And then we can see below. So let's keep talking about this. Let's talk the dysbiosis index. So no great surprise, this individual is raging with dysbiosis. And accompanying that is a drop in diversity. So speak about that. Where is this dysbiosis severe in this individual? What do you see commonly? And then what does the diversity score tell us as well?
Yeah, absolutely. These are excellent matrices. And the dysbiosis index is a marker that's characterizing the information about abundance and diversity and looking at the key bacteria we'll talk about later, such as Akkermansia eosinophila, fecal bacterium parotenicidea. Those are really heavy hitters in the gut microbiome. So their populations are heavily weighted into the computed algorithm to create the dysbiosis index, but it is looking at all of the bacteria detailed on pages 2, 3, and 4. So the way GI360 is organized is that first page has all of the data, the pertinent findings. And that first piece of information we have is phyla, that's broad information. And then we get more and more detailed. So the dysbiosis index is there. As you mentioned, the scores go from 1 to 5. 1 to 2 is a normal, healthy gut. That's really where you want your patients to be. 3 is moderate, so you could consider interventions at that point. And then 4 and 5 is dysbiotic. And as this patient shows, the dysbiosis index of 5 is significant. This is significant dysbiosis. And this score specifically has been studied in populations with IBS, IBD, obesity, diabetes. And then you'll find many peer-reviewed journal articles about microbiome dysbiosis in general. So you could extrapolate this information to those concepts.
And conversely, again, you and I were talking about it offline, that when we see a diverse gut and we see a lot of those keystone players like Akkermansia, the dysbiosis index is lower, and that's associated with longevity.
Yeah, that's one of my favorite findings about the blue zone information that we have now. Maintaining microbiome diversity into longevity, I personally think is a really important.
It's cool. Yeah.
Yeah. So microbiome diversity is also on the GI360, and that's a really unique marker.
Well, so again, walk us through the diversity score and what you see with this individual. And by the way, before we go into diversity, the dysbiosis index, I mean, again, you've looked at thousands of these reports, being an in-house, clinician educator at Doctor's Data, and you have your own practice as well. What extent of dysbiosis do you see routinely?
Yeah, so it's a fairly nuanced topic because, again, I do tend to see the cases that are either metabolic syndrome or in nature where there's that consideration of conditions as well as GI conditions. So I really do see the scores of potentially 3, 4, sometimes 5, sometimes 2. 1 is not too common. I have some excellent cases of 1 where an individual has remediated a standard American diet. Oh, wow. Yeah. So generally in those cases, it's going to be on a recommended, potentially modified Mediterranean diet. The Mediterranean diet has a lot of good components that are very nourishing to the gut microbiome.
Oh, that's cool. Good to know. All right. And so the diversity score.
Yeah, diversity is really important, and it's not a quite well-known marker. Right now, there's over 5,000 peer-reviewed journal articles that are associating microbiome diversity with health outcomes. So it's actually well studied. Clinically, we're not really applying it as much as we could yet. So the diversity score in the colon is it's not unlike any ecosystem. So think of the diversity of the rainforest, the diversity of the Great Barrier Reef. You want an abundance of multiple bacteria in your colon. It's the same concept. So it's a foundational component. It's not only associated with GI health directly, but it's also associated with systemic physiology. So this has been studied with conditions such as chronic disease, but also colic in infancy, extroverted behavior, disordered eating. And we know that individuals on a standard American diet display decreased microbiome diversity, and individuals that had a higher microbiome diversity previously before immigrating to North America, they end up with decreased microbiome diversity. And this actually exaggerates with each succession of each generation.
Oh, that's pretty interesting.
Yeah.
Wow.
Yes. And then one last thing about diversity that I think is important. There is one study that they noted that individuals that had lower microbiome diversity did not show a benefit from probiotic therapy. We're using probiotic therapy quite ubiquitous in our clinics, and I think it's important to be aware of that.
So if that's the case, how are we going to best influence diversity score?
Yes, good question. So that same group of researchers, they did another study. And what they did was they took two groups of individuals and they allocated them to either the high fiber group or the high fermented food group.
Okay.
Yes. And they were able to study these individuals over a 12-week period. The individuals in the high fiber group needed to add 20 grams of fiber per day. And then the individuals in the fermented food group needed to add at least 2 servings. So by the end of the study, they were averaging about 4 to 6 servings of fermented foods per day. And what happened at the end of that study was that the fiber group did not denote a significant increase in microbiome diversity, whereas the fermented food group, they noted a significant increase in microbiome diversity, and they noted a decrease in 19 inflammatory proteins, including interleukin-6, and then cytokines. So potentially there's a connection here with increased improving microbiome diversity and decreasing inflammation. So again, we're connecting it to the chronic disease, all the root cause consideration.
Okay, so that's fabulous. I certainly appreciate fermented foods, but I mean, we prescribe fiber all the time. We prescribe fiber in the form of a good whole foods diet. I mean, the Mediterranean dietary pattern that you just referenced before is a good high fiber dietary pattern. So what was remiss in this study to not see favorable outcomes with the fiber intervention? I'm really curious. What were they doing? And, what were they doing in the cohort that did respond? Like, what were the specific fermented foods? Like, why the difference? Were they just throwing a bunch of psyllium in the fiber group to kind of hit that target of 20? I mean, why are we seeing such different outcomes?
Yeah, not psyllium. I actually would be interested in the psyllium study. It was the largest category of fiber was fruit. So it seems to be self-directed. The individuals were just told, add 20 grams of fiber and put this in your food.
Here's what you can do.
Yeah. So given the choice, individuals largely chose fruit. Vegetables was an option as well. Grain was an option. Legumes is certainly an option, but when I look at the data from the individuals, legumes is a small portion of what they added. And that is key because there is a difference between soluble and insoluble fiber. Additionally, the researchers noted that their ratio of insoluble to soluble fiber increased. That makes sense to me because they chose fruit. So a quick information about fiber, because it is so important. I agree with you. Yeah. So generally speaking, if we're talking about produce is going to be 1/3 soluble to 2/3 insoluble. And if we talk about the difference between those, we need both. So insoluble fiber is the indigestible portion. That portion does not dissolve in water, and it helps basically move the bowel movement through. So I think of this when I think of a stalk of celery, you can take off that long, stringy, fibrous portion, right? You're not going to digest that. So that's that extracellular matrix, that's insoluble fiber. The additional portion is soluble fiber. And soluble fiber is this gelatinous substance. It dissolves in water, and this is what the bacteria eat. So you need both, but if you want to feed the bacteria specifically, you really need to increase your soluble fiber.
Interesting. And 20 grams is not the greatest amount. I mean, if you really wanted to improve a diversity score in your practice, what would you do? I mean, yeah, go ahead.
No, I mean, I agree, because again, 20 grams is potentially not enough, because the average American is getting 10 grams of fiber total per day. So remember what we said that about a third of it is going to be soluble. So that's only about 3 grams of soluble fiber. Our microbiome really needs 10 to 15 grams of soluble fiber per day. So that is the key, making sure you hit that level of soluble fiber daily intake.
So then we're looking, if it's a third of it, then we're looking at like 45 grams of fiber if we want to really diversify our microbiome. And then layer in some fermented foods. What did they use for their fermented foods in this particular study?
Yes, beautiful. I love 45 grams of fiber. I love that. So the fermented foods were everything from kombucha to vegetable brine drink, and then fermented vegetables, cottage cheese, kefir, and yogurt. Now, one thing as well, they did give a macronutrient breakdown, and the fermented food group slightly increased their protein intake because they were consuming more yogurt, whereas the fiber food group slightly decreased their intake because they were consuming more fruits. So there's a few nuances there with the study. The researchers hypothesized that it just wasn't a long enough time.
That's pretty interesting. Well, it'd be interesting to actually look at, the details on the fruit, and maybe take a look at blood sugar levels, and, and some of the systemic influence of, of that much sugar, and the influence of the sugar on the microbiome also, and shifting, the growth pattern of gut bugs. Obviously yeast is going to be feasting on some fruit, Candida is going to be feasting on fruit along with, many other players. All right. So I want to say that you've got this, folks, you have this sample report from our website, from the show notes page sitting in front of you. And all of the information that we're talking about, the way that they compile the scores is by looking at the rest of the data on the lab. So as clinicians, if you want to know exactly, what the growth patterns look like, or the presence of these particular bacteria, you can look at the balance of the report and get that information exactly. So for example, this person has a lot of proteobacteria. You can flip over to that section and actually see what's going on. What about the rest of this page 1, this fabulous summary report?
Yeah. So page 1 is excellent because you can actually just use page 1 of the reports, depending on how much time you have in your office or how much time you have with your patient. You can simply utilize page 1. You can go into it as much detail as you like as well. It's really your choice. So again, we started with the web, and then we have the dysbiosis and diversity score. Then the next piece of information, we have that last row is separated into 2 pieces of information. We have the GI health markers, and then we have the key findings. The GI health markers, this is microbiome data. This is functional guilds of bacteria. We are looking at bacteria that work together. As example, the first group is the butyrate producing bacteria. That's the fecal bacterium and the eubacterium. These are the bacteria that create butyrate. If it is within range for your patient, you have a green toggle. If it is outside the reference range, you have a yellow toggle. So you would know right there to make a clinical intervention. For the butyrate producing bacteria, you could utilize the soluble fiber feeding approach, because when you feed those bacteria butyrate, they ferment it. When you feed those bacteria soluble fiber, they ferment it and create butyrate. The next group is the gut barrier protected bacteria. Within this category, we have that keystone bacteria, Akkermansia muciniphila. So in this case, it's toggled yellow, meaning it's imbalanced. So we know that Akkermansia is outside reference intervals, and that's potentially compromising mucosal barrier integrity. So then right here at this juncture, you could support Akkermansia populations You can use probiotics, you can use polyphenols, you can use those together. And then you could also do your gut barrier protective protocol. I would do that as well, just because we know intestinal permeability is associated with so many of the conditions, chronic disease that we're talking about. And then the next piece of information
before you jump into the key findings, I just wanted to make a point on this. First of all, I just have to circle back to your earlier mention of probiotics not making a difference to diversity in that same study group. And by the way, folks, that paper will be on our show notes as well. And we prescribe probiotics all the time. So this is evidence, perhaps, I mean, it depends on what probiotic they use, but this is evidence, obviously, for leaning on, dietary changes as really being where the heavy lift is, and diversifying the fiber choices. I think if they were primarily eating fruit, and it also depends on what fruit they were eating. They just didn't do a good job at designing or prescribing the amount needed, as you already identified. But we use probiotics all of the time, and there's some pretty good research out there. I'm just curious your thoughts on that, and if you're using probiotics and how you might be prescribing them.
Yeah, great point. Excellent point. I certainly use probiotics. I think there's absolutely a place for probiotics, especially when a patient has a dysbiosis index score of 5, especially when a patient has low abundance, especially when there's a specific probiotic like an Akkermansia or lactobacillus and that's low. I certainly think that makes sense. I like to layer things, right? So we're using the probiotic, we're using the fermented foods, we're having those together. I think it makes sense to get the probiotic in there, but then feed the probiotic with soluble fiber, polyphenols, fermented foods. And it makes sense because you're giving your patient your dietary recommendation alongside those targeted nutraceutical supplements, of which probiotic falls into that category.
Yeah, for sure. I mean, I use Akkermansia as you and I have spoken about in the past, routinely, or Akkermansia combination products for certainly for the barrier issue. And then I use them for, some of the cool data around GLP, around blood sugar control, A1C, et cetera, et cetera. Let's talk about the key findings on this report. And we'll talk about the key findings in general, but I'm still looking at the sample paper here. And yeah, this person is in rough shape. They've got C. diff present. They've got, a couple of different not so good Klebsiellas, and they've got inflammation, et cetera, et cetera. But talk about those key findings.
Yeah, exactly. So GI360 is not only talking about the microbiome, we are looking for targeted bacteria, yeast, stool chemistries, parasites, inflammatory markers, immunology markers, and any findings there outside those parameters would be printed on this first page. Exactly as you mentioned, not only does this patient have significant dysbiosis, they have the bacteria of Klebsiella and 2 species of Klebsiella, and those are directly cultured. At the end of the report, you will find direct sensitivities. So that means that in the laboratory, they took your patient's bacteria or yeast, if applicable, in the laboratory, and the microbiologist put that in vitro with natural and pharmaceutical agents. So you have another opportunity here for individualized medicine for targeted treatment.
Okay, that's cool. So we can see that, and this again, going to the sample report, we can see that this person would respond. The Klebsiella pneumonia would respond to colloidal silver if they wanted to go natural, possibly caprylic acid, and all of the antibiotics would be susceptible. They'd be able to eradicate the Klebsiella with the exception of ampicillin. Okay, good. But that's a nice complement of different interventions. Oregano, golden seal, olive leaf, uva ursi, caprylic acid, black walnut, but really for the most part, none of them. Actually, ionic silver and colloidal silver both responded with a distant third in caprylic.
Cool. Yeah, and just a note of these, of course, in the laboratory, we test them individually, but if we know there's a synergistic effect potentially. So if you have a formula that has more than one in there, it's potentially going to show greater efficacy than what we can see on the report, if that makes sense.
Yeah, where you're testing literally one by one, right?
Yeah.
So how would we evaluate, what are we going to look at using this report to get a good understanding of intestinal permeability? What are the players we're going to be looking at? And, there's some other tests that we can add on if we need to.
Absolutely. So intestinal permeability is so important. We see it actually increasing in clinic. I'm sure, yeah, you've seen that.
Sure.
So intestinal permeability, we cannot directly measure it on this report. To directly measure it, you could simply add on the fecal zonulin. The zonulin family proteins do measure that. Yet we do know on this report that gut bacteria, Akkermansia, Muciniphila, fecal bacterium praenicii, they significantly contribute to mucosal barrier. So if those are outside the reference interval, that is a key that you have mucosal barrier integrity. And again, that is going to be indicated by that gut barrier protective toggle there. So it's quite straightforward to understand if you wanted to implement mucosal barrier integrity protocol. It's right there. Yeah.
Nice. And we can see, and then you can just at a glance scroll over to page 4 and then see that the Akkermansia in this individual is really low. It's significantly low. So one of our interventions is definitely going to be some of the polyphenols you mentioned earlier that can really help stoke Akkermansia growth. And then, we could consider using Akkermansia or an Akkermansia combination product.
Yeah. And another potential finding would be potentially low fecal secretory IgA. There may be many underlying considerations when we're talking about low fecal secretory IgA, but that's another potential clue. In this report here, we have a high fecal secretory IgA, yet that would be considered functionally high because you do have that Klebsiella, you have 2 Klebsiella and then that C. diff. So it's actually appropriately elevated in this case.
It's responding to the potentially pathogenic organisms present. Actually, yeah, and C. diff is there as well. So it's appropriate. It's good. This person doesn't feel well. This sample report. They're not happy with all of those findings. But plenty of time in clinical practice, we see people who've got chronic dysbiosis and secretory IgA just hits a wall. It can really no longer sustain producing that much. And our bodies, we just don't produce it. And we see low secretory IgA.
I see that quite often. And also individuals that are under psychological stress, that's also a finding that you may find.
Mm-hmm. Athletes will drop secretory IgA, after the stress of their season. At the end of their season, you can see them, their SIgA drop. And then they're all out there routinely, their sinus infections, upper respiratory infections, sort of things that aren't surprising would be associated with the fallout of low secretory IgA. And yeah, you could certainly see dysbiosis and gut issues creep in.
That makes sense. That's a really good point. Yeah.
So you look at Akkermansia, you're able to measure low, you're also able to measure high. What are your thoughts on high Akkermansia? This is kind of somewhat of a hot topic amongst functional medicine geeks.
Yeah. So we discussed, there are some few studies out there that is potentially higher in certain conditions, and it may confer a protective benefit. We don't necessarily know the exact mechanism of action for that.
Mm-hmm.
And then, I would say that when it is elevated, it is associated with dysbiosis. So when it's too high, it's associated with dysbiosis. But it brings me back to the fact that the microbiome really works synergistically and together. So if you have an elevated Akkermansia in your patient's report, there will be other findings to be addressed. I do not recommend eradicating that. As a matter of fact, nothing on that web or the first few pages of the report, pages 2, 3, and 4, do we eradicate. We're talking about feeding the microbiome and bringing things back into balance.
Awesome. I so appreciate that. I do think some clinicians are anxious about elevated Akkermansia. It is a keystone strain engaged in incredibly important activity, both locally in the gut, from maintaining barrier integrity to stimulating production of GLP-1 to, systemic influence, body-wide. So it isn't titled keystone strain for not. And yeah, to your point, I wouldn't, I definitely wouldn't recommend an aggressive eradication intervention. I have thought that, maybe there's an aggressive sloughing off of the mucin layer, and that's why you're seeing more akkermansia in the fecal bolus. Or maybe there is an attempt of the akkermansia to kind of respond to recycling sort of damaged mucin. I mean, it's probably a surrogate marker of something else and not in and of itself a pathogenic player. And that I'm getting is what you think as well.
Yeah, absolutely. And you bring up an excellent nuanced point about that sloughing off of that mucosal layer, because that mucosal layer is just so important in regards to physiology, because it really is modulating where our internal environment meets our external environment. The body makes 2 liters of that every single day. So it's a very important, it's a very important system. And we do see that some individuals do tend to slough that off. They tend to be very symptomatic, GI wise, but maybe even systemic physiology as well.
Sure. Yeah. Intestinal permeability being associated with pretty much everything. Very interesting. So these pages, the early pages in this report where we're measuring all of those different phyla, the specific players in the different phyla. Again, I just want to underline, you don't want to kill them. Don't go in for the assault, be it aggressive antibiotic interventions or botanical interventions. Rather, you want to nuance and balance.
Yeah, absolutely. Exactly. Yeah, we want to feed the bacteria that we need there, those anti-inflammatories, and when we want to starve those inflammatory bacteria, it's really largely about diet and remediating that diet. Yep.
Stress. So everybody's under chronic amounts of it. How do we perceive chronic stress? Like short-term stress can actually be this beautiful hormetic experience that could, be beneficial on the microbiome, I would imagine. But this chronic grating stress of a tough job, not enough sleep, stuck in traffic, et cetera, et cetera. How does that show up in changes to what's happening in the gastrointestinal tract and with the microbiome?
Yeah, absolutely. Stress certainly influences the microbiome. So stress itself can induce intestinal permeability. So it is a risk factor for that. As you mentioned, acute stress is appropriate. So you may see compensatory fecal secretory IgA, but over time, what we see is chronic decreasing fecal secretory IgA. Chronic stress downregulates fecal secretory IgA. And then, of course, elastase, because you cannot be in fight or flight and in rest and digest at the same time. Another consideration here is eating hygiene. So making sure individuals are sitting down and relaxed and mindful eating. But certainly stress does wreak havoc in the microbiome. When we are under the influence of these stress catecholamines, they can actually spill over into the microbiome. And these pathogenic bacteria, such as E. coli and Salmonella, they actually really enjoy those stressful catecholamines. And that environment can really increase their growth, and it can increase their ability to adhere to enterocytes, which of course we don't want, because once they adhere to enterocytes, they can translocate, we can get LPS into systemic circulation, and then that is, further maladaptive physiology. So stress certainly influences the microbiome. The other thing is, as you mentioned, if individuals are stressed due to our everyday considerations, it actually takes 6 hours. I saw one study that said 6 hours, another study that said 2 weeks for the environment in the microbiome to remediate itself.
It's incredible how potent the stress response can be. And to your point, we don't want to, if we're in a fight or flight, we're not going to be dumping out the necessary compounds. We're not going to be dropping our stomach acid to a sufficient degree to really allow for digestion to happen. We're not going to be, to your point also, releasing sufficient elastase or the other pancreatic exocrine enzymes that are essential for appropriate breakdown of foods. The other piece, I guess, just because my brain is, I teach the immune module, part of the immune module at IFM, and I'm thinking about allergic disease. We see the same kind of occurrence with insufficient digestion ushering in allergies, because those proteins are abnormal to our immune system. So if we're in this fight or flight and we shut down digestion, as we should, but we're also eating, those can become pathogenic. Those food compounds can become pathogenic to our system, who will, the system will identify those proteins as not safe and mount an inflammatory or an allergic response. There's some pretty cool studies on looking specifically at proton pump inhibitors and increasing the aggressiveness of allergic reaction, or actually bringing on new allergic reactions.
Wow, that's
I know.
fascinating.
It's super fascinating, and we're prompting a similar effect with the stress response.
Mhm.
So let's talk about GLP-1 agonists. They're the rage. The physicians are prescribing them all over the place, big time. Patients want them. I have a couple questions for you. First of all, you've had the chance to look at the laboratory data of people on GLP-1, and I'm really curious what you see, how these modify potentially not just the microbiome, but some of the additional chemistries, if you see changes and what happens. And then I want to talk to you about the fact that GLP-1 is stimulated by Akkermansia and Clostridia butyricum, probably other important strains as well. And this epidemic of dysbiotic guts may really be the underlying issue, the obesity epidemic that we're in, because we're not making GLP-1. So two questions I have there about GLP. Dysbiosis playing a role in, sort of inhibiting GLP-1 production, and in this era of lots of GLP-1 use, what you're seeing in the gut microbiome.
Yeah, absolutely. So certainly with the dysbiotic gut, we do tend to see that lower Akkermansia, which would potentially decrease GLP-1 production. Another consideration is actually soluble fiber. So as soluble fiber is in the colon, this can potentially interact with the enteroendocrine L cells, and there is a mechanoreceptor on there. So when they're providing a lingering physical tone, this can stimulate the L cells to release GLP-1. So in individuals that are fiber deficient, that are dysbiotic, they're at risk for potentially perturb both of those mechanisms of actions. And then as far as individuals on GLP-1 agonist medications, there's a variety of findings. Again, not every diet is created equally. So one of the worst dysbiosis scores I had seen was on a individual who was on a GLP-1 for a few years. And this individual was not eating throughout the day and simply having an apricot throughout the day and coffee, but then at night would binge on carbohydrates and alcohol.
Wow. And it was the worst dysbiosis score you saw. Whoop, whoop. That's huge. The worst dysbiosis score you saw was on an individual on a years-long GLP-1 therapy who had just adopted a pretty damaging dietary pattern. Wow, that's fascinating. Layer that onto muscle loss, and some of the other issues. They're certainly a less healthy individual now. Wow. The use of GLP-1, a lot of folks are talking about how it needs to be accompanied with resistance training and sufficient protein to inhibit the muscle loss or the muscle wasting even. But to your point that, we can really damage the microbiome.
Yeah, exactly. And so then that patient is going to be decreasing their endogenous production of GLP-1 even further. So they really need to remediate that. And as you're mentioning, when patients are on these medications, because they are so popular, it makes sense to take a look at their microbiome and adjust and support them along the way.
Sure. There's a lot of cool opportunities out there. A lot of clinicians in the functional medicine space are thinking about how you might toggle between tending to the gut microbiome, an appropriate whole foods diet, some of the various interventions to support increasing GLP-1 endogenously, and then, tapering down to, the lowest necessary dose of the GLP-1 agonist drug. And we can use this as a guide. We can use the information from the GI360 as a guide. Now, that was really interesting. why don't you, as we come to the home stretch of our conversation, just, review again what is on the GI360, just run through what we already went through, and then the things that we haven't touched on yet.
Yeah. So again, that first page is really a summary of the findings. You have that phyla information, you have the dysbiosis index, diversity score, and then you have that left column there. That's the health markers. So we're getting detailed information about key bacteria from the microbiome. And then you have that second column, that's the key findings. So any positive findings here, you could address them. In this case, the patient has a pathogen. So GI360 is also doing PCR testing for direct pathogens such as C. diff, as we see here. So those acute considerations. And then we are also seeing the information on here of the stool chemistries, lysozyme and secretory IgA, and the short-chain fatty acids. We know that short-chain fatty acids are so important because they're really a link between the gut microbiome and those systemic considerations regarding physiology. They are the microbial mediators that travel from the colon and stimulate end organ physiology. So it's really important to look at those. We look at valerate, propionate, acetate, and butyrate. So those are on there as well. Look, pH is on there as well. And then, of course, beta-glucuronidase. So beta-glucuronidase is on the report. Very important consideration, especially when we're talking about estrogen metabolism, when we're talking about individuals that are perimenopause. This is, PCOS, endometriosis, those conditions. Beta-glucuronidase does play a role. And it's important when we're talking about toxin elimination and endogenous detoxification, because it's tagging those conjugates and releasing them. So then they're potentially available to be reuptake into systemic circulation to be reabsorbed. So potentially reabsorption of toxins and hormones if beta-glucuronidase is too high. So it's good to take a look at that indication there. There's potentially a link between this level and breast cancer. So
are we mostly concerned about beta-glucuronidase elevated? I mean, that's my understanding. Do we think about, so this is reported, a low beta-glucuronidase is reported on this sample report. I mean, in the sphere of what's going on with this individual, how concerned are we about that?
Right. So beta-glucuronidase, we're concerned with elevated beta-glucuronidase clinically. It's known that low beta-glucuronidase is potentially associated with low diversity. So when you have yeah.
Interesting. Okay. So you want some beta-glucuronidase hanging around. You just don't want a lot of it. And low, maybe a surrogate marker of something else going on. Okay, good.
Yep. Now there is some newer information that it may be associated with IBS and IBD, but I would not say definitively yet. So let's
okay. Oh, interesting. Okay. There's plenty to do here on this sample report. So we don't really have to worry about the beta-glucuronidase or what we need to do.
Okay.
And I would bet that when you treat the overall gut, and you get this person back to balance and you tweak their diet, et cetera, you'll see that beta-glucuronidase just sort of bounce back into a normal range. Would you agree?
Yes, I would 100% agree with that. Absolutely.
Okay, cool. All right. So walk us through the next sections and then, spend a minute or two on the ones that we actually haven't really talked about.
Sure. So pages 2, 3, and 4, that's a summary of the information. So if you wanted to take a look at the specific bacteria, let's say bifido or lactobacillus or akkermansia, you have those levels there. So that's an important finding. Page 5 is going to be the pathogens information. So we're looking for viruses, pathogenic bacteria, and parasites on that page. So we're looking for those pathogens. And then page 6 and 7 is the parasitology. And it is important that this is the ova and parasitology. So this is still the gold standard parasitology information. So any finding on there is a positive finding. Because
sometimes we see, actually, I'm back. I'm at the pathogenic bacteria. This is where we can see that the individual has C. diff present. Doesn't have, you're looking at viruses, and again, as you said, the parasites as well.
Yeah, so everything is covered. And then sometimes the parasites could be found in their cyst or their ova. And a positive finding is a positive finding. So if you see an ova, that's the parasite there.
Okay. And then what else do we have?
So we have other markers, and these other markers can be fairly nuanced. We're looking at yeast under the microscope. This yeast is non-viable. This is the expert parasitologists and microbiologists are looking under the microscope and they see the cellular structure of yeast. Further on the report, we will have cultured yeast. Now, these are distinguished because yeast that's cultured is active and alive and it's growing in the colon. Yeast here can be associated with yeast that's been cultured. If you have cultured yeast, it goes together, life cycles. Some of them are alive, some of them are dead. It makes sense. But if you have a patient that presents with yeast symptoms and you don't have anything cultured, but you see it on the microscopy, you can consider SIFO, small intestinal fungal overgrowth. In that case, it's not cultured in the colon, it's in the small intestine, but you can see it under the microscope here.
Wow, that's pretty interesting. So in a symptomatic individual, yeast present, but they're not culturing, this could just suggest C5.
Yeah, and we can't provide sensitivities, obviously, because to do sensitivities, we're taking that live isolate.
Yeah, you need that. Yeah, for sure.
Yeah.
Okay. And what else are we looking at here?
Red blood cells, white blood cells. We are also looking at muscle fibers, vegetable fibers. We spoke briefly about the carnivore diet. I do tend to see red blood cells and muscle fibers in the carnivore diet due to that red meat consumption. With red blood cells, one of the considerations is also hemorrhoids. So this is fresh blood. This is fresh in the colon. Of course, you can see that with considerations of IBS, IBD. So the markers here really need to be considered in the context of the other findings.
Okay, and the person and what's happening with them clinically and so forth. So red blood cells could be active hemorrhoids, could be an active bleed and somewhere, and in a carnivore diet person, it could be evidence of eating a whole lot of meat. So you need to just do further investigation to confirm or rule out. Okay, what else do we have?
We have the muscle fibers, vegetable fibers again. The Charcot-Leyden crystals are going to be associated with parasitology, and then pollen is actually an incidental finding. It can be associated with allergies, but it's really just a finding that is of note within the colon.
So it's not anything that's going to inform your clinical decision making?
Not at this point. It's more of an observation, correct?
Okay. And then there's the macroscopic appearance, be it, the color, the consistency, and the presence of mucus.
Exactly.
Any comments on those?
Not to discount those, sometimes people, those aren't the flashy findings, but they can provide us information, yeah.
Sure, it could be evidence of constipation, there could be mucus, obviously inflammation, for sure. Yeah, and in this individual, in the sample report, I think it's loose, and as it should be if you've got a C. diff infection. Exactly. Okay, all right, what else do we have?
So then the next page is the culture page. And this page, I will tell you, of all the years and all the GI360s I've seen, I've never seen two pages alike. This is really individualized. Yeah. The first section is the pathogenic bacteria, the Aeromonas through Yersinia. That will always be printed there because we're always going to culture and let you know if those are found. The next group is going to be imbalanced bacteria. The imbalanced bacteria, you can really see anything here from 0 to 12. These bacteria take up space in the colon. They're not significant players, but they do take up residence in the colon. You'll potentially see more of these imbalanced bacteria if there's less of abundance of the bacteria from the first section of the report. Now, the other consideration here is that this is identified via the MALDI-TOF library, and that library is updated every 6 months. So as microbiology evolves and we can understand these bacteria more to species levels, so sometimes these names are actually updated.
Oh, interesting. Can you just speak to that, what the MALDI-TOF technology is and the MALDI-TOF library?
Yeah, so the MALDI-TOF technology is essentially identifying the genomic fingerprint of each bacteria. And once it's cultured, it's using that data set that is a global library that is associated with research facilities and laboratories all over the world. And it's identifying the bacteria that the genomic fingerprint that was identified, and it's matching it to the library. And yes. So even at Doctor's Data, we've had one discovery of the Larybacter Hong Kong genesis. It was the first one in the world. Yeah.
Wow. Congratulations. Did you guys get an award? That's pretty cool.
Yeah.
I think that maybe we can throw a little something on the show notes about the MALDI-TOF technology. That would be nice to make available to people, because this is the next generation culture, right?
Yeah.
This, if you're using culture, it should be done in this way. Would you agree?
Oh, absolutely. Yes.
So this imbalanced bacteria, would that also have any influence on the dysbiosis or the diversity score? Could this directly or indirectly influence page 1?
So this is going to potentially be a byproduct of page 1. So
Okay.
as you'll see here, we have like a Corynebacterium. So we have bacteria that we see on the skin. We have a lot of staph and strep, and those are bacteria that, we are a very bacteria rich organism. And so sometimes you'll have something in the oral cavity or on the skin that goes along for the ride in the colon. It's not really going to significantly influence colonic health, or it's not really going to influence systemic physiology. But as you know, the colon can't have any empty spaces. It has to be filled with bacteria. So if we don't have those good bacteria that we want,
there's room.
Yeah.
That's pretty interesting. So maybe if they were very high, you would be a little more suspect, but for the most part, it's more an incidental finding, would you say?
Correct. Yes.
Okay. All right. Go ahead.
Now, those bacteria, we have some that are value driven. So some bacteria in smaller amounts, such as Citrobacter and Klebsiella, they would be considered imbalanced. But if they're larger, we kick them over to the next category, the dysbiotic category. These bacteria are categorized that they will contribute to GI symptomatology in your patients. So these patients might not feel well with, they may have diarrhea, stomach pain, things like that. So we have, yeah. Mm-hmm.
And in this one, we see both of the Klebsiellas that were reported on the first page.
Exactly. Yes, correct. And then last but not least, we have yeast. So in this case, there's no yeast grown, but if there was yeast grown, it would be put here, and then yeast outside the reference interval will also be provided direct sensitivities.
Cool. And then one of my favorite parts of the report, I love the chemistries, and you guys there are a ton of chemistries on the GI360. Why don't you run through those?
Yeah, I always say this page has a wealth of information, right?
It is. Yeah.
So the first section is going to be digestion and absorption, as we touched upon. So elastase, that pancreatic enzyme there. We have a fat stain. So if you have individuals with fat malabsorption issues, I'd also pay attention to diet, right? We talked about ketogenic and carnivore. So sometimes individuals are consuming, yeah. And conversely, there are still individuals who are eschewing fat and abiding by that low fat diets. So that might not give you the best clinical information, because it would still be none in those cases.
But we would see people who are doing sort of a fat bomb, kind of a peanut butter nut olive oil breakfast or whatever, you can see a really high fat and you don't have to worry about steatorrhea or fat malabsorption.
Well, I wouldn't say you don't have to,
Okay.
but you can't differentiate those. But yes, it would make sense that that's going to be your first thought. Yeah. So.
So confirm that with your patient. And then if you are concerned, I guess you'd have to do a follow-up. So one of the things you could do, if you remember, and I'll admit that I don't often advise people before testing, you could say, look, don't eat anything high fat before you obtain your stool specimen.
Yep. That's certainly a consideration. Yep. And then the next one is carbohydrates. So carbohydrate malabsorption, we can see that there. So that's the digestion and absorption. And then the next section is the inflammatory markers. So here are the markers associated with inflammation. The first one that I would consider is lysozyme. Is in the middle there, because lysozyme is non-specific. So if we have elevated lysozyme, as we do in this case, we don't know why. We have to look at the other findings on the report to see. Now, it makes sense because there's that C. diff. We have two dysbiotic bacteria, and then we have a high dysbiosis score. So this is an inflamed gut.
Okay.
And
so
then,
that's consistent with that. Yep.
Yeah,
okay,
absolutely. And then lactoferrin and calprotectin, those are specific for IBD. Those are different.
Or in the case of super high, calprotectin could be colon cancer, actually, right?
Yeah, and another consideration would actually be if you have a potentially an enteropathogen, a really malignant enteropathogen. You can see those markers as well. It is a marker of destruction of the colonocytes.
Okay. Okay, both of them?
Yep. Mhm.
Okay.
Yeah.
Then we've got the immunology.
Yeah, fecal secretory IgA, which is a very important biomarker as we've been discussing. In this case, it's elevated appropriately. More often than not, you will see low fecal secretory IgA in the considerations that we've discussed, stress, mucosal barrier integrity, and then of course, the considerations of vitamin D, vitamin A, zinc status, those play a role as well.
Interesting. So this is good that this person has a high IgA in the face of all of the other elements that are happening. So they're able to respond to the assault with IgA. But if it wasn't addressed, we would anticipate seeing this drop. Short chain fatty acids.
Yeah, short chain fatty acids. Now, these are intricately linked to that first section, that microbiome section, because they're derived from that microbiome section. Now, if you'll notice, there is two pieces of information here. The first 4 markers are percentage. So we have percentage acetate, percentage propionate, percentage butyrate, and valerate. And again, this is important because we're talking about balance and relation to one another. So we're talking about those levels as they relate to one another. We don't necessarily have a treatment protocol to say, you know, if acetate is higher, we need to absolutely do this. It's about bringing everything into balance based on the microbiome abundance and diversity portion. Now, the next piece of information is the absolute frank values. We have the frank value of butyrate and then the frank value of total short chain fatty acids. Because these are both so clinically relevant, we look at these absolute values here.
We want to make sure there's enough butyrate and overall short chain fatty acids, given the incredibly important roles they play. Yeah. Okay. And then the balance of markers.
Yeah. So we have pH, and pH again is associated with that information that we saw at the beginning, the microbiome. You know, we tend to see that lower pH commonly, and sometimes you're thinking of patients that have food sensitivities, lactose malabsorption. So that can potentially be seen on here as well. And then we have that enzyme beta-glucuronidase, that important biomarker, and then occult blood. Occult blood is different than the red blood cell. Occult blood is hemolyzed. So this is coming from the upper GI, potentially an ulcer, esophageal varices. If this is positive, you do want to follow up with another second test in 4 weeks to confirm.
All right. And then let's see what else we have here on this cool report. Then we go into the various sensitivities that we already talked about, where you guys test the natural ingredients as well as the prescriptive agents against the dysbiotic organisms.
Yes.
Yep. Okay. Go ahead.
We just updated this list. So we, in collaboration with physicians like yourself, we updated the natural agents list to provide the ones that are applicable in clinical practice.
Nice. It's a good list. It's a nice, robust list. And then I want to just add that there's a pretty long discussion section at the end talking about the imbalances in the individual, right? So you don't dump everything. It's specific to the report at hand. Is that correct?
Absolutely correct.
Awesome. So that's useful too, if you want to do a little bit of a drill down into your patient case. Well, this has been fabulous. I really, I appreciate all the hard work that you've done. Any of the papers that we've referenced, you guys will be on the show notes. Again, the sample report will be over there, and we'll get something about MALDI-TOF technology for you to read about if you're curious about that cultured methodology that they're using over at Dr. Stata. Do you have anything to add to us to this conversation today, Dr. Malkowski, before we say goodbye?
No, thank you so much for having this conversation. It's been excellent to have this opportunity to talk about the microbiome.
Awesome.